Super exciting to see that radioligand therapy is kind of a broader topic of discussion. Sometimes I feel like I'm at a meeting and I'm the only one sort of beating this drum, but it's unbelievably exciting kind of the era that we're in. I specifically went into nuclear medicine because I didn't ever want to see a patient again, right? I'm like a introvert. I wanted to just sit in a dark room and look at images. Now the best part of my week is seeing patients in clinic and explaining things about radioligand therapy and what to expect. And I think as we'll see as we kind of sift through the data, the reason I'm so excited about that is that these are efficacious agents and they're very well tolerated. So they really have both sides of the coin relative to maybe some of the harsher, more cytotoxic things that we would typically give a patient. I'm going to start out my talk and sort of go through a short litany of things that light up on PET but aren't prostate cancer, just so that we're all on the same page in terms of an awareness of these things may lead you to believe that the patient has PSMA avid disease and they don't. And then I'll go through some of the data, some of which you've already seen, particularly kind of from a overall meta-analysis level, as well as, of course, vision. Vision is hard to get away from. All right, I think I have the same conflicts of interest I had this morning. At least I don't think I've acquired any in the last couple of hours. And then I think I also kind of went over this slide earlier today, that there are certain things we know about prostate cancer as regards PSMA PET, and particularly that we can use it as a means of selecting patients for radioligand therapy. All right, so here's an example of a case that this patient would not be a candidate for radioligand therapy. It's a relatively unusual case. The patient has peritoneal carcinomatosis. They also have liver lesions. Those liver lesions are specifically PSMA negative. And so this worries you, I think, as a patient who's sort of transitioning into a neuroendocrine phenotype. And sure enough, on biopsy, histopathology tells the story. So we were able to both target his peritoneal carcinomatosis, which still had some sort of adenocarcinoma features. So still had a little bit of PSMA expression, still had a little bit of AR expression, but his liver mets were distinctly PSMA negative. So we do have to be aware of these patients. I think everyone sort of debates how to define this disease state and how common it is. I hear some people throw out the number, 20+% in kind of end-stage disease. I don't see nearly that many on PSMA PET. So I don't know that that's actually the case. I think this is actually relatively unusual. But again, this patient, we would specifically say cannot get radioligand therapy. We would not have any reason to believe he would benefit from it. Here's a run-of-the-mill compression fracture. So older guy, kind of frail, low bone mineral density, and between a baseline PSMA PET scan and a follow-up PSMA PET scan, he develops this compression fracture. It has PSMA uptake, but it's a kind of PSMA uptake distribution that doesn't suggest that he has an underlying lesion there. So again, there are going to be false positive things in the bones. Probably everyone in this room has had a patient that they've gotten a PSMA PET scan on, and that patient has a solitary rib lesion, and someone who may not be all that experienced in PSMA PET says, oh, hey, prostate specific, it's got to be prostate cancer. I'm going to call this a rib metastasis. And usually that isn't the case. Usually these sort of isolated bone findings that don't have a strong CT correlate that would make us suspicious are often going to be benign. If we look more broadly, I guess these would be less pitfalls and perhaps just normal variants. So the peripheral ganglia as neuronal structures, neurons actually express PSMA. Now we call it glutamate carboxypeptidase or nalidase when it's in the brain or in these peripheral neuronal structures. But nonetheless, these are things that are going to have uptake. They can look like lymph nodes. They can look like bone metastases. We have to be very careful in interpreting them. Here's another example of that, and another example, and okay. And then here's another bone finding. So this is a patient that has Paget's disease of bone in their sacrum, which is a relatively unusual site for Paget's. Bone scan was read as metastatic prostate cancer to the sacrum. I don't know that that's how I would have read this. I think it looks unusual. We should wonder if an entire bone being involved is something that's more metabolic or benign and not so much prostate cancer. And this poor guy, he's a salvage radiation candidate otherwise, but he's told he has a bone metastasis. He happened to get enrolled on a clinical trial that included a PSMA PET scan, and that lit up. And so the medical oncologist came to us and said, "You're saying this is Paget's disease? I don't believe it. I think this is prostate cancer because it has PSMA uptake." So ultimately, the guy wound up getting a tumor protocol MRI, which is the image you see in the upper right. And the key finding on that image is that his bone marrow in his sacrum still has a fat intensity signal. So it's a T1 weighted image, so fat should be bright. And interestingly enough, it is. And so that tells you there isn't an infiltrative metastatic process here. This really is just Paget's. Post-radiation changes can have PSMA uptake, and that's probably some combination of hyperemic effects from the inflammatory process that's induced. Perhaps eventually you wind up with some neovascularization, and at least in non-prostate solid tumors, that's often the driver of PSMA uptake. So it could be something along those lines, but again, we do want to be cognizant that post-radiation changes may have some PSMA uptake. All right, so that's my quick rundown of pitfalls. Now, I don't think that necessarily any of those individually is probably all that salient to an individual patient. We're usually looking at patients that have widespread metastases. It's relatively unusual that we encounter a patient who's sort of burned through a lot of their other systemic therapy options and is going to wind up being a candidate for Pluvicto if again they have a relatively limited or low volume metastatic burden. Now, I'm ever the contrarian, so I think this morning I sort of threw a lot of maybe unnecessary cold water on certain ideas with PSMA PET on the diagnostic side of things, and here I'm going to I'm probably going to be contrary to maybe a little bit of what you heard in terms of the balance between efficacy and toxicity, because lutetium is in the grand scheme of radionuclides, a relatively gentle radionuclide. If we think about, say, thyroid cancer patients that are getting iodine-131, iodine-131 is still a beta emitter, so very, very similar emission, but a much higher energy beta. So the betas that are given off by lutetium are, if you will, relatively wimpy. And that's one reason that we don't necessarily have a lot of the toxicities. But of course, we also then bump into things on the efficacy side, where something like an alpha emitter or an Auger electron emitter, those things are going to be way higher linear energy transfer, and they're going to do a lot better job of killing the tumors. A lot of those more hopped up radiation types will cause DNA double strand breaks. And so only loss of the target is going to sort of allow the tumor cell to survive. Otherwise, it is going to be toast. But of course, then you look at things like the salivary glands on a PSMA PET scan, and those look just like tumors, and the radionuclides are going to treat them as such. So the really, really horrible toxicities that you sometimes hear about are more associated with those types of radioactivity that aren't FDA approved and are being used in varying settings and primarily in Europe and Australia. I suppose it's good for a lot of people's academic careers in those places that they don't have an FDA. Right? It's pretty easy. You don't have to do any IND work. You just kind of like, you could basically take shoe polish and inject it in a patient if you think that's right, and you're totally okay with that. But it's maybe also good that we do have an FDA that's sort of keeping us from maybe harming those patients. I'd also note that, and this is sort of maybe a broader failing of the educational and training programs in the U.S. In Germany, if you want to be a nuclear medicine physician, that's a 4-year training program as a standalone training program. Those folks have admitting privileges. They order labs. They help fix toxicities. They round on patients every morning. Nuclear medicine in the US, if you're trained as a radiologist, is 1 year. So, we don't have admitting privileges. We don't round on patients, generally speaking. We do sometimes have to bring patients into the hospital, but in doing that, we have to collaborate with other services that sort of are going to help us manage some of the toxicities and do things like order labs and other stuff that we're just not accustomed to. So there's a very as we think about translating the things that are being discovered or at least investigated in places like Europe, we do have to be aware that the training of the physicians who may be carrying those out may be much different. Now, all that being said, like I said, I want to kind of be positive here. So, lutetium PSMA 617 or Pluvicto, and what is kind of a sister molecule to it, lutetium PSMA INT, which for all intents and purposes, as far as I can tell, are statistically identical in the literature, despite what I think are, as was pointed out, some maybe not totally great decision making in terms of trial design with the latter agent. If we take a look at all the metastatic castration-resistant prostate cancer patients that have been treated on various predominantly single-center studies, and many of them retrospective, so they do have that limitation, we'll find that somewhere around 40% of patients will have a PSA 50 response in those studies. So these are, again, heavily pretreated, they're metastatic castration-resistant, they're often post-chemotherapy. And so while it's not a magic bullet, that's a pretty good objective response rate. Somewhere around 70% of patients will have some sort of a PSA response, but that still means that 30% of patients are going to be primary refractory to this treatment. And so, I think in the zeitgeist that's out there, patients often have an idea that this is, again, hey, it showed up on the PSMA PET scan, I'm going to have a response to this. And as we're starting to unravel some of the biology, I think it's interesting to look back at the other agent that your nuclear medicine physicians may be using, which is Lutathera for midgut neuroendocrine tumors. Also a 30% primary refractory rate, which suggests that there probably is some final common pathway where these patients just by happenstance, their bodies are really good at repairing single-stranded DNA breaks from radioactivity. So I would expect that everything else we roll out that's sort of beta particle based, probably going to have a 30% primary refractory rate. All of this comes at again, what are generally very manageable toxicities. So in terms of nephropathy in the short term, generally there isn't any. I have a hard floor below which I won't treat a patient. That's a GFR of 30. And that's not really because I think I'm going to necessarily damage their kidneys any worse than they may already be damaged, but you start to get really long circulating times with those radioligands because they're not being filtered by the kidney. And so then your hematologic toxicities and things like that start to ramp up. So I think down to 30, we don't really have any data that we should necessarily worry about those patients, but below 30, I think it's generally common in the community that we're not really treating those patients. And then if we look at xerostomia, so this is again, I think everyone's very acutely aware of xerostomia as a toxicity, primarily because actinium-225, PSMA 617, which is being used with some regularity in Germany and some other parts of the world. It really just absolutely obliterates people's salivary glands. It makes them absolutely miserable, ruins their quality of life. But it's always, I guess, a tit for tat. So the first guy who was ever treated with that agent, he was given about 2 weeks to live by his oncologist. 2 years later, he was still alive. So he was miserable, but he was alive. So, where patients sort of draw that line, if you have a patient that's like, hey, I gotta survive another 6 months. I got a kid graduating from college, things like that. There probably are people that are willing to sort of make that quality of life sacrifice, but it isn't going to be every patient. And as we do move into those perhaps more hopped up types of radioactivity, we do have to be aware of that. In terms of, but with Pluvicto, yeah, a lot of times after cycle 2 or 3, patients start to have a little bit of xerostomia and may sort of, note a little bit of pain along the jaw. I don't know if anyone remembers sour lemon warheads, but these incredibly sour candies. I'm like, hey, go take a sour lemon warhead, get your saliva going, and you'll be just fine. And that generally is the case. Generally, we're talking about grade 1 or 2 xerostomia. So patients that experience that, it's usually either self-limited or fixable by relatively simple methods. And then, of course, there's the vision trial, and PSA response is great, but overall survival is better, and certainly progression-free survival is better, and even freedom from skeletal events is better. And when you add lutetium PSMA 617 to standard of care, across the board, you sort of wipe the mat with just standard of care alone. I would say that just a quick anecdote here. So Oliver Sartor, the first author of the vision trial. I was at some symposium somewhere, and he was speaking right after me, and I used the term supportive care, and he said, no, it was best standard of care, not supportive care. And so he kind of fact-checked me in real time. And but the paper actually says best supportive or standard of care, so I kind of feel like I was still a little bit right, but far be it for me to argue with Oliver. All right, but let me maybe start to wind down a little bit with the idea that we are in an era where we don't necessarily have FDA approval for everything or guidelines approval for everything, but we know we know from the literature at least how to follow patients with PSMA PET. If we give them cytotoxic therapy, if they develop new lesions or they have a significant increase in tumor burden after receiving therapy, we know that that's a bad sign. We know that they're progressing, and we also know that if all their tumors kind of go away, that's probably a really good sign, or maybe they develop neuroendocrine prostate cancer in the interim. But a lot of other therapies that we might give systemically do weird things to PSMA PET, and so I do just want to highlight that as we think about response assessment criteria in this setting, it isn't necessarily always trivial. So when you interrupt the androgen signaling axis with something like ADT or abiraterone, enzalutamide, any of the above, that actually drives up PSMA expression. So while the tumor may be responding and becoming smaller, it may become hotter, and it may be really, really hard to actually tell whether a patient is responding or not. Here's just an example of a couple of patients that were imaged at baseline and then a couple of months after starting Abi or Enza, and their tumors did all sorts of crazy things. Now, I think there's opportunity there because we can probably come up with metrics that may allow us to not only figure out where people are on a waterfall plot, but may also allow us to stratify them in terms of progression-free survival or time to therapy change, or even overall survival. So there's imaging biomarkers kind of hidden in the data, and particularly as we move to hopefully incorporating PSMA PET into more clinical trials and imaging patients more longitudinally over time, we'll hopefully start to tease out some of those imaging biomarkers. Same is true for bipolar androgen therapy. Of course, PSA is sort of utterly useless in that context. So we do need to define radiographic progression-free survival, and progression on bipolar androgen therapy is going to be an imaging game. Turns out if you use PSMA PET, you can find patients earlier. And so again, I do want to emphasize that if we're kind of in this perpetual cycle where we're using CT and bone scan as our imaging for follow-up and clinical trials, we're going to be missing the boat on opportunities to better incorporate PSMA PET into that landscape. And I do want to point out this is work from a former postdoc of mine, Dr. Andre Gafita, who some of you may know. If you don't, you'll definitely come across his name in the future. He's first author on a Lancet Oncology paper that was the first to sort of define nomograms for patient response to lutetium PSMA therapy. And he's developed something called RECIP, which kind of like RECIST, only with PSMA PET. And this really does allow us to, I think in a very validated way, he has a number of papers in very high impact journals, validating this in different contexts and showing that it is a predictive biomarker of whether patients are really responding. And so, hopefully this is, again, something, we're going to get away from RECIST, we're going to get away from even PERSIST, which was sort of the FDG PET version of RECIST, and hopefully kind of charge into this idea that we can in a very sort of standardized way figure out response to these therapies. And I realize I'm kind of bumping up against my time here, but I also want to emphasize that there are lots of things hidden in PET scans that may be very valuable to us in terms of imaging biomarkers. And I know that was a topic of discussion this morning on MRI. It's also true on PET. But radiomics doesn't work in PET. So probably in the time I've been up here, there have been another like 50 publications on radiomics and PET. But the vast majority of radiomic features are not actually repeatable, and that's for fundamental physics reasons. So I'm not sure why we're putting so much effort into that. And artificial intelligence, well, I hope it doesn't put me out of job in the near term as a radiologist. And I think lots of other jobs are going to go by the wayside first. So I'm not too worried about it. But AI is already really good at finding things on PSMA PET scans. What it isn't so good at is characterizing those things. So that solitary rib lesion that may be miscalled as a solitary metastasis on the PSMA PET, a lot of the AI algorithms that are out there are still going to pick that up. So there's a characterization element to AI that we really haven't gotten to yet. And with that, I'll close with a couple of conclusions there. Thank all of my collaborators, and thank you for your attention.